we kind of, oh, sorry, yeah, got it. No, don't worry. Actually, they asked me to record it. Good that you've done it, Boone, because one of your trainees, ACP, asked if I can record it, but you could do it. That's good. So the ABC ICH bundle is all about spontaneous intracranial hemorrhage, and we talked about it, me and Aftab before, and we produced a care bundle where we thought it will help you flow these patients faster into HAZU, because the whole idea of it at that time was, these patients need an anticoagulation reversal, blood pressure control, and criteria for referral to neurosurgery. By the way, Boone, we're not going to present the AF because I now got the access to the app. So I'm going to actually share with you screen-wise. After we do the presentation, I'm going to share with you how the app look like, which is more useful. So we'll spend the time on the presentation and then we'll go to the app as well. Not that you will need to do the app yourselves, but at least, have a feel of what it means and what you think about it as well. You may feed back to me as well, because we have the option to update, upgrade, and amend the app to our needs. That's more important. So we've done the ABC bundle first time. It didn't actually get used too much. But then these people in Salford in Manchester used the same idea, but proved that they can reduce mortality by third by using an ABC ICH bundle. And now it become a regional thing. So they are applying that for the whole of the North. We are in Sheffield, Chesterfield, and Doncaster, the first cluster applying this. And what they done is they created a care bundle for their own area. We have our own bundle as well, but they produced an app that help you go through that process. And I'm going to talk to you about this step by step. So first, I'm going to present in this presentation some of our data from SNAP data, which is the national data for stroke. And then I'll move on to Salford, what's their findings. And then I'll move on to how we're going to do this ourselves between us and ED, and what is our responsibility as stroke, and what you could help us with, and how is that useful to ED doctors. So this is a case actually not long ago in ED. I remember one Wednesday, it was so busy. It was like about 3 weeks now or more. It was dead busy there. It was madness, like Beirut, as they say, although Beirut now is more mad than any place in the world. This guy, the right side CT scan, the small bleed in the basal ganglia, is how he presented. So it was right-sided weakness, a small bleed. He's on, I think, rivaroxaban, if I remember, or apixaban, one of them. Somebody from ED called the ACP nurse, and the response from ACP nurse was, oh, do a scan and do this and that. I was like, and she was handing over to me, and I was like, no, you don't want to just say that. You need to go down. You need to go down. You've got the protocols. You've got the Bareplex protocol. You've got the blood pressure protocols, and we should go down as well. So by the time I come down anyway, his GCS was 15. He was well, his blood pressure was high. And I said to one of the juniors, I'm not sure if he's with us today, that, let's do the blood pressure control. And we couldn't find it on the system. I couldn't find it on ED. I couldn't find it on our intranet. And it's a fault from our side as well. We thought it's always available, but it was only available in the ACP bag as a document, nowhere else. Anyway, we printed it out. We gave it to him. The blood pressure took a little while to give the labetalol in this case. This patient needed every 5 minutes blood pressure, and that was impossible in ED in that day. I went up to find him a bed because I knew this is a small bleed. He doesn't need neurosurgery. It's a basal ganglia. And I was preparing the criteria as well. I'm working on that project for the last 3 months. And I said, he come up to HAZU. That's it. He called me back. He said he's deteriorated GCS 12, and the CT on the left side now, the big bleed, as if you can see it, is what was his scan look like after an hour, only an hour. So I went down again. We moved into Rhesus, managed to get Bareplex. Well, actually, he was having Bareplex even running when he went to the second scan, to be honest. But it was a little bit of delay. Now, I don't think it was a massive delay. It was like just about, because the new criteria is to do the Bareplex within an hour and a half. is to drop the blood pressure within an hour. And I think he was just about an hour, hour and a half from, first diagnosis or first recognized intracranial hemorrhage. But it was just a bit messy as everything was happening in ED at that time. It was like we didn't know the pathway was, or the blood pressure protocol was available or wasn't available online. The nurse was busy to do blood pressure for us every 5 minutes. It's almost impossible. But this gentleman died about a day later in the stroke unit. The issue is not how did we manage that. It's the issue here is we still don't have a clear pathway, a clear protocol. We still have this habit where we see a bleed, or we get somebody with neurological symptoms, we go to CT scan, oh, thanks God, it's a bleed, even not stroke, because we're not going to thrombolize them, so we're happy. Kind of like, okay, so it's a bleed. Well, actually, it's the opposite. We should respond to those, and I keep telling my ACPs now and our trainees, our juniors, that we should respond to the intracranial hemorrhage exactly as we respond to the thrombolysis call. We should be down waiting for them at the front door. We should be with them all the way to the scan, and we should start the ABC bundle straight away as well. And that's what we're going to do going forward. Could he have died anyway if we delivered everything faster and quicker and more smoother? Maybe, because the mortality rate is about 30% in intracranial hemorrhage anyway. But it's just an example, and nobody to blame on that one. As I said, it was just unfortunate, and it wasn't too late between the first scan and the second scan. So can you all hear me well still? Good. So I'm just going to show you some data, and you don't really need to go into details of these data. If you can just look at the graph and see how variable and the numbers are. So this is just the numbers of intracranial hemorrhage per month. This is from July 2019 all the way to July 2021. These are our patient that comes through ED to us in the hyperacute stroke unit. And you can see, like, sometimes we get 12, other times we get 2, 3, 10, 12. So it's just very variable. That's the blue line. And then the yellow line represent the one who are on anticoagulation, and the purple line are the one that are eligible for blood pressure lowering. So it's only about a third of intracranial hemorrhage patients that are eligible for that, kind of anticoagulation, blood pressure control criteria that we're talking about as well. How we're doing, this slide represent again the patient on not on anticoagulation, patient on DOACs and patient on warfarin. So you can see that the purple is the warfarin. It's getting less and less. There's hardly anybody now with AF in stroke unit or discharge from stroke unit that is on warfarin anymore, unless there's a specific reason for that, like metal valve or other reasons, particularly like alveolus thrombus. Now we use warfarin instead of apixaban. This is, sorry, I'm going back. This is now the time, and that is an interesting graph, because you can see, like, you can go from an hour 52 minutes, an hour 37 minutes, to an hour 48 minutes, to 3 hours, to anything up to 4 hours sometimes, which is all, again, the graph is up and down, and you can see this is just, this variation means we are not doing it right. All this should be a straight line, almost always within an hour for reversal, or an hour and a half, they say now in the guidelines, so 90 minutes. And that represent just the quarters from 2019 to the third quarter of 2021, how variable the way we're doing it, and how fast we're reversing the anticoagulation in those patients as well. Even how fast to get to scan as well. Blood pressure lowering. The blue part is the patient are eligible for blood pressure lowering. And the yellow part is the one that were eligible but didn't receive it. Again, there's a good percentage here that not getting the right treatment. Similar to previous, this is another demonstration of how variable how up and down our management is in blood pressure lowering or reverse of anticoagulation. You can see some spikes up to many hours, which doesn't make sense. Sometimes you look at it and say, like, what happened here? You want to just go and search for that particular patient and find out what exactly happened on that day. But it's always variable. It's never a straight line. It's never within time as well. Case fatality, that's another thing to talk about. So the average mortality from intracranial hemorrhage is about 30%. And as I mentioned, these people in Salford reduced that to 20% by applying an ABC ICH bundle. And that's like nothing, almost nothing you could do that you could drop the mortality by third by simple care bundle and a fast, quick response to these patients. And you're not doing anything magic. We're doing the same standards, the same protocols, the same guidelines. We're just applying it in a faster way and more organized way. And again, the mortality varies from 30%, 20% to up to 44% in some quarters as well, which is quite significant. But that's the mortality, discharge mortality. But then you get the 6 months functional outcomes, and the black one is dead at 6 months. And you can see that could be up to 50%. So that's above national average even in some quarters for us, meeting national average in other quarters, but 50% is too much in some quarters. Now that's Q4 2019, who knows, and maybe that was during COVID and our management was not great overall in everything else, and which just maybe were focused too much on COVID at that time. This is now moving to how important intracranial hemorrhage, as I mentioned, is 30–40% at 1 month, about only 20% regain independency after intracranial hemorrhage. And it's quite significant number of disabled patients after intracranial hemorrhage. It represents at least 1 in 3 incidents of strokes. So 1 in 3 strokes to 1 in 4 strokes, essentially, you will have intracranial hemorrhage. But it's not very common. If you saw the numbers, it's about 12 to 15 a month, which is not a lot of patients per month. The Salford protocol. So what they've done in Salford between 2015 and all the way to 2017, they produced that project, which called ABC ICH. They applied it and they measured the outcome. They said, we want to reverse anticoagulation within less than 90 minutes. We want to do blood pressure within less than 60 minutes. We want to create a pathway that is clear for us and for the ED doctors that says, this is the type of patient we want to refer to neurosurgery. And these are the patients we want to straight send up to the hyperacute stroke unit. And you see the graph here between the blue, the green, and the pink. And the blue is after applying the project, and the numbers is 243 compared to before, which is the pink 354, and they simply dropped the percentage by 10%. I mean, dropped the death mortality from 30 to 20%, and that is a third in reduction. Sorry. They want to take this up to the whole of the North, and that's where we got involved. So myself in Doncaster, I'm the lead for the project. In Sheffield, we've got Dr. Hartness, she's a neurologist. In Chesterfield, we've got the team from Chesterfield. And we have an overall South Yorkshire lead called Dr. Redgriff, Jessie Redgriff. She's also a neurologist. She's the South Yorkshire stroke kind of lead as well. And the blue area is all the areas that are involved in this project going forward. And it's all, we are South Yorkshire, we are the first cluster to start. And you can see in this graph how we're starting. So we are region 1. We started in August preparing for the project, and the launch is December. The rest of the regions, they're just going to follow us in that pattern. Some will take 4 to 5 months, 6 months, up to 9 months. But we are the first region to start with the shortest period given to us. In fact, it was very intensive. I managed to get the protocol that we've already established with you guys amended, adjusted. That same protocol now is used for the whole of South Yorkshire. We managed to get a neurosurgery approval for criteria for referral. And that wasn't the hard part. The hard part was getting the app approved, because it has a patient data into it. So we had to pass it through IT and DPIA forms and information governance, all this being done, all being approved. It went to the patient safety regroup as well. So all that is being sorted. I did send it to you guys through Aftab and Kai. I'm not sure if you discussed it in your governance. The only thing I'd hope for is that nobody comes later and say, oh, I didn't know about it. I haven't said that yesterday. I met Mohammed in the shop floor and he said, oh, I haven't heard about it. So can we make sure people hear about it? But I'm trying my best. I've done one teaching already in the Thursday case of the week, and this is the second one for you guys. But please, we need to make sure others know about it as well. You don't need to be bothered about how we're going to do it. There is a central region, and then there is central lead, and there's a regional lead, and there's a trust lead for each one. There's a few questions to ask there. Does implementing that bundle improve survival? We're going to monitor that. We're going to audit that for 1 year. We actually bring in 6 months retrospective as well. All the patient that was 6 months before the project launching. We're going to also do a year from the project launching. The audit department involved. There is a survey questionnaire that will be sent out to the patients who had intracranial hemorrhage. We will track every single patient and we will see whether they died, what's their disability, what's their mobility, what's the level of independency after 6 months as well. And how is that going to help, overall, even from economical point of view? And, which part of the pathway, need adjusting, amending, and that's why we're meeting together today and other days to say, like, does that suit you guys? What do you want? I've just been talking to Ivor in radiology, asking him if he can report for us the volume of the bleed, for example, which they're going to look at it and do it for us as well. So all these things we're doing in the background. Any questions so far? Sorry, I'm giving you too much information there.
Actually, can you hear me?
Yes.
Actually, what happened, the protocol was sent to Firas because he's our IT lead.
Yes.
To put on my ED.
Then,
so, then clinical governance leads. I mean, somehow they have to put their foot in every matter. Jenny, what her name is, she some sort of block or some objection. So then I told her, listen.
Do you mean the old one? Do you mean the old one?
Yeah, I told her nothing to do with you because this protocol is trust-wide and it has already been approved by the trust patient safety group and everything. So nothing to do with you. Then she came back. I think then it was put on my ED on the blood pressure control and the.
To be honest, after I've amended all that pathway. By the way, I was a bit upset when I got this email. To be fair, and you know me, like I'm literally pro ED.
It has been proved by the trust.
I know, but then when I heard that the first pathway was removed from the ED intranet, I was like, oh my God, now. And then the reason why it was removed, again, it was because some miscommunication, people heard about it, people didn't hear about it. When I replied, I said, this is a stroke pathway. I mean, it's supposed to help ED, not the opposite.
No, any good thing, there are people who won't like it, is it?
Don't worry. Look, we're gonna take off that.
Anyway, so this is I'm pretty sure this is on my ED now.
Yes, well, even that after, let me just be clear. Even that one, this is the one I'm talking about. This is now completely renovated. And I'll show you the new one, because as I mentioned, now the new one is the South Yorkshire one. I don't think anybody can remove it anymore. You have to have permission. You have to have permission from the whole South now.
Of course. I think if the new one, if it's not, then send me. We'll put my on my ED.
It's only
make sure it's.
I'm only waiting for the link for the app to add it to you guys, so you can actually become in your intranet. When you click on it, so it open up the app. I'll explain it in a second. Definitely, I'll explain it in a second. Anyway, the project is going all the way to April 2023. It's a long project. I committed myself to it, so let's see how it goes. I've got with me as ACP nurse. I've got with me a data collector as well, and after represent ED until I don't know how long. There is also Amy, a CP trainee, who was a stroke ACP, and she knows well. She wanted to help with this as well. As I mentioned, Kai is aware and the governance lead are aware of this, but I just don't get much replies, to be honest, other than you guys now attending. Kai did attend one of the training session. He really enjoyed it. He had his feedback, and we also managed to update the app as he said how we wanted. It was very important what we've done when Kai also attended, and I'll explain that when it comes to the app. All this being approved, I'm not going to go through that. The guidelines, there is a lot of guidelines behind this. The stroke, the NICE guidelines, the Royal College guidelines, the European Society Organization, sorry, European Stroke Organization. There is a lot of guidelines, so there's a lot of evidence behind it about prosthrombin complex concentrate, vitamin K from NICE, from Royal College, from European Society again, all this established. The idea, the most important bit that you need to know, guys, about it is that if the patient presented within 6 hours, this is a patient we need to target in a very aggressive way. This is a patient we need to drop their blood pressure to around 130 to 140 target within an hour. And that's where within an hour comes. So patient coming with neurological symptom, he goes to the scan, they either stroke as ischemic stroke or a bleed stroke. If they are bleed stroke and their symptoms are within 6 hours, we will be aggressive and we will be starting the blood pressure lowering protocol with a target of 130 over 40 systolic within an hour. And if they come more than 6 hours, then it's only if the blood pressure above 150 to 220 to actually reduce that blood pressure gently rather than aggressively, I should say. Although the NICE says aggressively there, we decided to go gentle in those patients. So because we think after 6 hours, the hematoma expansion is already established, and we just go gentle in lowering blood pressure there. The second part is the NICE guidelines as well for neurosurgical referral. Again, you don't need to be bothered about that, but just evidence of where we got the information from and how we established this new criteria that you're going to see in a minute. But it's all evidence-based, right? So the whole aim of the project is to reduce mortality by 10% or by a third in 6 months' time. We need to meet targets as well while we're doing this project. We need to be achieving at least 90% of the patients who are eligible to be reversed. Similar for blood pressure lowering, at least 90%, and similar for care pathway or criteria for referral to neurosurgery. We need to refer those who are meeting the criteria, about 95% of them, and we don't want to refer too much people. And I still remember one time where a patient was in Rhesus, a 95-year-old from a care home, a massive bleed, GCS3, and the junior doctor in ED, bless him, he called me, I was there, I can't remember, he called me down or I was there. And the first thing, bless him, he was doing is actually logging in line to go to refer a patient. And I said, just stop that, let's speak to the family. And that's where I want to be involved. That's where we need to be focused on. It's like, which patient we say this is palliative, stop, do nothing. Which patient this is aggressive blood pressure management, reversal of anticoagulation, and which patient we do that and refer to neurosurgery. And which patient should be straight away from ED door to CT up to hyperacute stroke unit and not landing in ED at all, exactly like we do with thrombolysis. These are our data collection, how we're going to measure it. The ABC ICH app was also going to produce data. And this is how the app looks like. So I'm not going to show you the screen because I'm actually going to log into the app, to the real app, to the demo and show you exactly how it's going to happen. But I don't know if that would work. Could I try it quickly? This is a video. If you don't hear it, let me know. Can you see it? Boone, can you see that?
No, it's not playing for us.
No, you might need to switch the the thing that you're sharing.
Yes,
because you're sharing the PowerPoint right now, isn't it?
Yeah. Forgive me. I'll share again. And we are supposed to share this one. You're correct. Let's hope at last time didn't play the sound. It didn't make sense to people looking from the other side. Tell me if you hear it. If you don't hear it, let me know.
Stroke is the second biggest killer in the United Kingdom, and about 10,000 strokes in the UK are caused by an intracerebral hemorrhage or a bleed to the brain, and it has the worst outcomes of all stroke subtypes. For every 10 patients that we admit, around 3 are expected to die during their hospital stay, and of those who survive, around 5 are discharged with moderate or severe disability. So our aim is to reduce the death and disability caused by intracerebral hemorrhage by providing outstanding care for all patients. To help achieve this, we brought together guideline recommended care to create the ABC Care Bundle. In 2015, we ran a quality improvement project to implement the ABC Bundle at Salford Royal Hospital. And the number of deaths caused by intracerebral hemorrhage in the 30 days following its introduction dropped by around a third. So what's in the ABC bundle? Well, the A is for rapid anticoagulant reversal, and we expect up to 1 in 5 intracerebral hemorrhage patients to be taking an anticoagulant or a blood thinning drug, and reversing these quickly prevents the risk of further bleeding into the brain. The B is for intensive blood pressure lowering, and all intracerebral hemorrhage patients benefit from good blood pressure control, and more intensive control for patients who arrive at hospital within 6 hours also reduces the risk of further bleeding in the brain. The C is for a care pathway, which is about getting the right patients referred to neurosurgery as quickly as possible. So what's next? We're working together with stroke teams across the north of England to achieve excellent intracerebral hemorrhage care through our ABC ICH Scale Up Quality Improvement Project. For this next phase, we've created a mobile app to ensure stroke clinicians managing ICH patients in the emergency department have key information at their fingertips. The app will also capture important care quality measures, displaying these back to the local team in an automated, continuously updated dashboard. This means that teams can quickly see where improvements can be made and focus on their implementation without having to spend their time collecting audit data from the clinical notes. So each regional group of hospitals will be led by a local clinician, and they'll meet regularly, sharing what has worked at each hospital and what hasn't, so that they can support and learn from each other. In order to understand the costs and benefits of participating sites, we'll also be using routinely collected national audit data to see whether death and disability are reduced and to estimate the overall cost of the project. We're also conducting parallel research to understand what factors help or hinder the project so we can refine our approach for the next phase of the work.
All right, I hope you heard it well. So this is how the advertising for it down in Manchester now. What I'm going to do next is, sorry for this, let me just escape this. Sorry. And I need to go back to Zoom and share with you the actual app. This is. Can you see this page?
Yeah.
Great. Okay. So this is the app where it's going to be pushed to your desktop now as a little shortcut. Like, you know, it's a browser-based app. It's not an app like you need a phone or iPhone or anything. It's just a link on the NHS kind of domain where it's secured and it's approved and all that is sorted. You will have it as a shortcut in your desktop. We will have it in a stroke. We will have it also on some of our iPads. What you need to do, I'm going to show you how it works. So what I did when Kai mentioned, oh, are you going to get a username and account to every ED doctor? I said, oh dear, no, because there's too many. And I said to the developer, can I make it similar to refer a patient where the ED doctor can simply log in without logging in? So we created that just for ED guys. So I'm going to log out from the app first. And that's how it looks like when you log in yourselves. But instead of logging in and having a login username and account, which we will have, but you wouldn't, we agreed that you can go into some sort of a generic access. You can start things if you like, although my plan is for my ACP to start everything, but in case, you know, who knows, time busy and you want to start doing stuff, by any means, you could do that. You don't need access. All you need to do is start clicking at new patient, if you can see that. Once you put new patient there, you can just put your, let's say, I'm going to put my details for now. Nothing to hide. And it will ask you about your NHS email. And your hospital, which is now all, as I said, we made each version of the app personalized for each hospital. So Doncaster will have the Doncaster version of the app, if that makes sense. Because Doncaster app will also show our protocols, our guidelines, how to manage blood pressure, our care bundle, our Beriplex also. Everything that we do in our trust is going to be shown in the app. So we're not going to be using, if anybody wants to put complaint on me, that's my GMC number. There you go. So then you logged in. So as an ED doctor, you don't need a login. You just need your name, your GMC number, your email. And the reason for that is just for data and medical legal reasons. So if an ED doctor wants to put patient's data there, he can simply, or she can simply just put their email address, their name and GMC number. It doesn't need a login. And that's when Kai suggested, what are we going to get an ED, all the ED doctors to have a login. After that, it's patient details. So it's, let's say anybody, whoever, it takes about 50 minutes total to show you this anyway. So I'm going to say NHS unknown, for example. Date of birth, yes, perhaps we can choose anything. 17. Yeah, something like that. A scan at external hospital, usually no, because it's scan in our hospital. When did you do the scan? You can say now, and that just get you there. After that, it's next. A stroke occurred as inpatient, usually no, but if it does, you can put that details. You can go back on that a bit. Let's say we're going to do it live. Happen at 9 o'clock today. Onset date time known, yes. And yeah. That's when the time last seen well. You can even add this. It's not best estimate. Has a decision been made to withdraw? So this question came up also as discussion with the app developer. So we were talking to them and said, what if we've decided this patient is for end of life? We don't want to go through ABC. We don't want to go through the filling the form. So if you say, has a decision been made to withdraw active treatment for this patient? If you answer yes there, that's it, you're done. You don't proceed to anything else. If you answer no, then it takes you to the second level. And the app itself give you the other options, you know, GCS documentation. And then at that point, you probably as ED doctor don't need to do any of that, or you'd like to do it by any means. I wouldn't say no, but then the app will go through ABC for you. And each time you do a section, it takes about a minute for each section, no more. For A, anticoagulation. For B, it's for our ACP nurses. They're going to record the blood pressure. They're going to add a reading for each 5 minutes. And then for C, which is more important for you guys, let's say he didn't have any problems, as modified Rankin score is 0, has the criteria met, you can answer that. Yes, no, it's all simple. So that part where Kai said, my junior doctors can't do, this is ICH volume calculator. That part now is going to be solved by our radiologist reporting in the CT report saying the volume for you. However, it's dead easy. You can just do the calculation by measuring 3-dimension. And if you don't know how, it does have the picture for it. And if you don't know how, it does have a video to watch. So you have 3 options. But again,
so this is
I don't expect you to reach that point, but if you got to that point, you don't know how, there is a video, two minutes video to do it. There is also a picture to do it, and all that is available. Once you finish ABC, you complete it. But each time you do something, the app actually, I don't want to go through every single part of it, but the app actually takes you into our guidance, our links for each part of it. Even when we say blood pressure, when you start adding reading, it will just show our blood pressure protocols as well. So that's the app. Now, what will happen if the ED doctor adds some patient data without a login? When the ACP logs in, they can just search for that patient and then take that patient. They own that patient now, and they become responsible. So they can actually search for that patient. As long as you chose the right hospital by clicking Doncaster, they can actually pick that patient and take ownership from there onward. Any questions for that? It shouldn't take more than 5 minutes, but the app is a live thing. So you'll be doing it while you're doing other stuff, but not you as well. It's supposed to be our ACPs, our juniors who does that. But I'm just
Ahmed, is this app on our desktop now, or
it will be pushed to you? This is the demo. This is the demo one. After
no, I would suggest, because we have a clinical pathway on our desktop where there is like a fracture neck of femur pathway.
Yeah,
I don't know whether we could incorporate in that clinical pathway, because all doctors are aware of that that app on that icon on our desktop.
Yes, you're right, because again, after sharing this today is just an introduction. As I mentioned, the care bundle is coming. The app will be pushed to the desktop from the IT, all in place. It's just waiting for that last version to be approved. Okay. So I'm still updating few things on it. I'm trying to make it so simple to you guys, so you kind of you know, everything you want to know about ACH. Not just you, our ACPs, all the blood pressure protocols, all the Beriplex protocols, they're all in the app now. And
it's good, is it? Because we waste, I don't know whether I should use word waste, because almost everyone who's got intracranial bleed. So at the moment, by default, though, we told them this is the criteria to refer, these are not referred.
Yes.
In spite of that, everyone, you know, almost everyone is put in the Sheffield pathway.
Yes.
And they might expect about, I don't know, 1%, 5%.
I agree.
So almost everybody, they say, no, admit locally, control blood pressure, repeat CT.
That's why the new pathway, that care bundle, this one now you see, and this is a South Yorkshire care bundle now. This is going to be in ED Sheffield. Is going to be in ED.
Right. Because from ED point of view, because you know, sometimes it's quite stressful when you are you know, through to Sheffield waiting for the response, and a lot of patient waiting, and your colleague is looking on your shoulder.
Yes.
Oh, what the hell he or she is doing now? He is very busy. So that's very stressful. I think from ED point of view, really it will be really very simplified and lot of time saving, lot of stress.
The new pathway after, let me say two things will happen now. One is there is a pathway that even in it, that paper one has all the links for our other protocols, the Beriplex and all that. And you'll have the app with everything as well in it. The app is because of the project. The app is more stroke thing, because the ACP, our stroke ACP will come down, meet the patient, go with them to the CT and start the process. Most of the time, that's what's going to happen, like a thrombolysis patient. And other times, what I'm hoping is that if there is a delay, the stroke ACP at night is dealing with thrombolysis, call upstairs, and the junior doctors in ED or anybody would like to start that process, then there is this protocol in front of them, and there is the app if they would like to proceed and start the logging in the patient. But the new pathway is so quick, it's so simple, it's all about ABCDE and all that.
Well, it's very
and it's also ABC as before, but now I'm just gonna move, because that for you is nothing. All what you need to know is that part. I know what you want. You want that part. That is the part that is important. Is neurosurgery referral required? yes or no. Indication for new surgical intervention. They want 4 patients. 1, GCS less than 13. Okay, so 1, they should be modified Rankin score 2 or 1 or 0. Okay, so 1, 0, 1, 2 only. So that's the first step. Anybody above that, modified Rankin score of 3, 4, no. 2, they should have 1 or more of GCS less than 13. 2, ICH volume more than 30. Posterior fossa ACH, that's cerebellum or brainstem. Obstruction of the 3rd and the 4th, and radiological evidence of hydrocephalus. Now, anything other than that is a no. If the ICH volume is only like 10 mil, the GCS is 14 or 15, the modified Rankin score is whatever you want it, then it's a no. If the other way around, if the modified Rankin score of 4 or 5, and then you got an ICH volume of even 50, it's a no. Now, what they say though in the purple part is they will leave that little bit of gate for you to, as a clinician, if you feel like, actually, I still want to refer that patient despite not meeting this criteria, blah, 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 it's fine, you will do it. But what they're trying to say here is, I don't want every single patient to be referred to us. And that has come now from the neurosurgical team in Sheffield for the whole of the South, the same criteria. So that would give ED, that 4-5 lines, they give the ED the option to just decide straight away who should go, who shouldn't. Does that make sense?
Absolutely, yeah.
Brilliant. All right, and out of that pathway, there is not much. It's all about, again, what we said, it's stopping anticoagulation. And as you see here, I've got a link, you click on it, you open the Beriplex link. We've got the blood pressure lowering, you got a link on it, you click on it, it takes you straight away to the blood pressure lowering. There's also the heparin reversal. I've just got that one. I need to update it today or tomorrow. And up there in the top, I'm going to add the link for the app itself. So if in case you don't find the app on the as a shortcut in your desktop, if you got that document somewhere in your intranet, you can actually click on that and it takes you to the app website as well. So that's the hope. Now, how is that going to work? It all depends on human factor, isn't it? So a perfect guidelines would mean nothing if we don't work together on it. And the reason why I'm presenting today and other days. Yeah.
So this, everything will be bundled together on that icon.
Yes.
I think that, I mean, it's very, very easy, is it?
Yes, well, that bundle will be in your intranet for sure. It will be in the Trust intranet as well. It will be available for everybody in the Trust. But the other option we're going to do is push that app into your desktop, so it show as an icon on your desktop.
I think better show an icon, because when it's easy, because when new people A&E are always people are turning around, is it? When the new people come in, just somebody in induction, it shows when the IT person do induction, because they normally show all the things on IT Symphony. So that's the thing on the Symphony. That's on the desktop. Yeah, yeah. I mean, equally, it can be put in Symphony as well. There are ways to
whatever you want. Yeah, whatever you want after, whatever makes it easy and quick for your juniors. The idea of this patient, my idea is this patient should not stay in ED. They either transfer to Sheffield or they come to hyperacute stroke unit.
Absolutely, yes.
So that's the whole that should be the process in anybody's head downstairs. Is this patient meeting criteria for surgical referral? Is he unstable, need ITU input? Shall we get an ambulance and get him there? Reverse the anticoagulation, do the blood pressure, that's fine. You'll do it at the same time. Or he doesn't meet the criteria, he's stable enough, he goes up to hyperacute stroke unit.
I think what next is, when is complete and ready. So yeah, please let us know then.
Oh yes, it's 13th of December is the launch. These will be all available for you before that date. Literally just everything approved. It's just technical now. It's all IT business now.
Because we have our dedicated IT person is Stephanie.
Okay.
She's very good in IT, Symphony and everything.
I'll be sending it to you after Kai and Firas. Is that Firas who does it?
Yeah, that's fine.
Yeah, I'll send it to you 3, and then again, please, by any means, pass it by your clinical governance. But as I said, it's not a stroke. It's not an ED pathway. It's a stroke pathway.
So we have to be realistic, is it? For instance, the clinical governance lead is to do something internal ED. This is a trust-wide, this is a region-wide.
Yes,
it's already been approved, been tested, been discussed about, been thought about. It doesn't come under clinical governance remit at all. So,
but by any means, Aftab, I don't want to repeat the same mistake.
Oh no.
All right. Who's else on the team? Sorry, I can't see everybody. I see Rachel, very familiar face.
So anybody else, Jan, for the DD training or no?
Please, anybody ask, please, I'm here for you guys. So I was going to present AF, but I thought it's too complex for you guys. But I just want to make sure you're aware there's an AF pathway now. I hope so.
Yeah. It's on my ED up and running. Yeah.
Perfect. Okay, so I don't need to talk too much about it. Well, we'll focus on that today, but please, any questions, I'm here to answer.
Oh, no, you can talk about AF. Why not? We have a time.
Are you sure? Any questions for the ABC ICH? Any objections? Anything we could do better?
Now, in this app, Labetalol and GTN, because logistic of using GTN is easier.
I know. We said after you see, it's funny when this guy presented this pathway, this project to me, I said, he said, oh, you got 3 months to start this. I was like, I'm not sure about that. Actually, we start our GTN infusion at 0.3 rate. Sheffield started at 0.6 rate, and you started at 1 point something rate. That little thing, that rate thing, need approval, need changing a whole pathway. And I came with the idea that each hospital should have its own version of the app. They wanted to apply Salford version on us, and I said, then you're gonna change the GTM policy, the blood pressure policy, everything. So this is our policy. Haven't said that after. It's not wrong or right. If you decide you want to start with GTN first, do it. But Sheffield do differlogistics. I
mean, it has to be like a flexibility, is it? Labetalol logistics are a bit complex because the person has to be there, keep on injecting, keep on.
Yeah, but we start GTM patch first, for example. It's not like which one is better now. It's more about how easy to give.
Doing something, is it? Just
we thought labetalol faster because it's a bolus. It's a 10 milligram. You just get it and then just give it. That's how it happened. In Salford they do different. In Sheffield they do it differently. Each trust does it differently. That's why we created DRI version of the app, because we didn't want to change our policies. Otherwise it would have taken a year to get that up and running. So the way around it was to actually change the versions, and each hospital have their own version. But by any means, first, second, third is just. It's just, and it's just there for you. If you think GTN is faster to be prepared and you want to deliver the fastest, you want to make it faster for patient to get the blood pressure low, just do it. I don't mind. Even we give hydrolysine. I don't. It's for example, hydrolysine is before GTM, by the way, before nitrates in our protocol. So I would never give hydrolysine. Do you know that? We never actually give it. We always jump from labetalol to GTN, so it doesn't really matter. Okay.
Yeah, also there are different options available which we could use. Clinician can use on its own.
It's gonna take you 20 minutes to get labetalol ready, and it takes you 5 to get the GTN. By any means, do the GTN. That's all right. So, but Beriplex we have to. By the way, regarding andexanate alpha, I've been told it's available in the trust, but it's not approved for intracranial hemorrhage. Does anybody know about andexanate alpha? Oh, guys, come on. I've been waiting for it to come to England for 5 years.
No, it's available.
Rachel is shaking her head.
It is available. I don't know, but I've never seen being used in air.
It's a very expensive drug. I think last time I heard it's about like something ridiculous, $40,000-$50,000 when it was available in America. Actually, the antidote for apixaban, rivaroxaban, it wasn't approved for edoxaban a few years ago. I don't know if it's approved now. But as you know, there is the dabigatran. We use the Praxbind. You should be aware of that one. Don't shake your head, Rachel. Praxbind? Come on. Yes? Okay, good. So Praxbind is available for dabigatran, all right? This is available in the trust for sure. So patient with intracranial hemorrhage, warfarin, apixaban, rivaroxaban, edoxaban, they use prostaglandin complex concentrate. Patient with dabigatran, which is very rare, we got a Praxbind. Now, we do have andexanate alpha for apixaban, rivaroxaban, and maybe for edoxaban, I'm not sure. But I've been told by Dr. Medlock, hematology consultant, that they're not approving it for intracranial hemorrhage, but for GI bleed and others. So please make sure you know about this as well. Very expensive drug. All right. So,
I've never seen being used in A&E, Adinex alpha.
Maybe because you're not using it after.
No, because I think it might not be available.
I'm sure it needs hematology. No, I've been told it is. It is, but I don't know where they're keeping it. I don't know. I'm sure you need to speak to hematology for that one.
I think, yeah, that's another thing, is it? Because if we want to use it, we need to speak to hematology doctor.
And for prostaglandin complex concentrate, by the way, again, ICH, you do not need to speak to hematologists.
No, we don't.
You just give it, just another thing to confirm. All right. Shall I then stop sharing this and show you quickly the AF pathway just for people who don't know about it, and then we're done?
Yeah,
is that
please.
all right, guys? Yeah.
Please.
Okay, so it should be straightforward, that one. Yeah, I'm interested in two things: the one that stop the clot and the one that make you bleed. So I create a pathway with Dr. Payne for AF, give apixaban, and then I have to deal with it in the other side where you need to stop the bleed when you have intracranial hemorrhage. So that's my two pathways. So the AF pathway, this is now available as well. The reason for that, guys, let me just give you a little background. The reason for that is similar to that case I presented earlier. There was a case who ED doctor seen the patient, diagnosed AF, she was in heart failure. He's done everything right. He referred to the arrhythmia clinics, asked the GP please to consider increasing furosemide, blah, blah, blah. But they didn't start anticoagulation in this patient. She goes to GP, again, she's tachycardic, 150 in AF. The GP increased the bisoprolol. She comes again, second time to GP, she was unwell, or maybe the second time she actually came straight to ED. When she came to ED, she came with heart failure, pulmonary edema, fast AF, and a stroke. And she died within 3 days with a massive MCA stroke. When I went to discuss this with Kai, and I said, what's our pathway down in ED? And they show me the pathway where it says anticoagulation and all this, and Shadvask and Hasbled. I said, do you actually give anticoagulation to patient with AF if Shadvask is high? And he said, no, we don't have the time. We can't counsel the patient. We don't have the time to give a apixaban. So I said, well, that's not right. We need to sort it out. So we spoke to acute medicine, because I'm acute medicine as well. It's easy to get things done sometimes speaking to colleagues in AMU. So we created a pathway that you can bypass this by patient with new diagnosis AF can now be treated and identified by ED doctor and come up to ambulatory care unit for anticoagulation same day or second day if they happen to be at night. I'm talking about those who are stable, like they came in with AF, you rate control them, and then you know they are meeting the criteria for anticoagulation, but you don't have the time or the skill, I don't know, for anticoagulation prescription. They can come same day to ambulatory care unit to be prescribed and counseled, or the day after if it happens to be at night, and that reduced that time to less than 24 hours. But then that was the pathway, and then cardiology got involved, and they said, oh, actually, what do we do with those one on flecainide? I was like, oh God, so we need to do one flecainide patients as well, the pill in the pocket. Oh, what about thrombolysis? Sorry, what about rhythm control? So we end up with a big pathway. But the pathway, the whole idea is for those patients who come with new AF, where you rate control them, you want to send them home, you don't send them now anymore for arrhythmia clinics to pick up in many days, like this case that we had, unfortunately died from the AF, not being given anticoagulation. The idea is to bypass all that. So the pathway looks like that anyway. It should be in your intranet. And it has two types of patient, the patient who are non-AF coming with fast heart rate, or the patient who are new AF. There are some certain patients that cardiology and Dr. Payne need you to know about. They are called, they are patients who are paroxysmal AF on flecainide. These patients should have a pill in the pocket kind of letter from cardiology. You look in Medisec, you will find it. There will be an advice from cardiology how to treat them in recess and get them home. So there's that group of patients, very rare, very small proportion of patients. And there are the patients that are new AF, and I'm not going to tell you what to do for new AF. It's simple, it's rate control most of the time. There was a huge debate among ourselves between rate control and rhythm control if patient come within less than 24 hours. All the data, all the evidence now is that many patients will rate control themselves, actually will reverse into sinus rhythm within 24 hours if you give them the time, which means there's no rush to reverse anybody unless they are having, unless they are compromised. Does that make sense? So in general, rate control is the principle in AF now. Rhythm control only when you're doing a, blood pressure low, shock, the criteria for shocking the patient and electrically cardiovert them. But most patients will actually revert themselves or convert into sinus rhythm if you give them the time. But the rate controls are beta blocker, calcium channel blocker, and digoxin. And the pathway actually take you through all that. You have the choice to discharge the patient if the heart rate gets below 110, even though they're still AF. And you can decide there in that green box there, whether this patient meets the criteria for anticoagulation and then send them to ambulatory care unit same day or second day. There's also potential that certain patients who are fit, young, with age 40s, with a heart rate 110, 130, that can go also straight to ICU as well for a little bit of time for rate control, or they're going to get admitted to CCU or AMU. So the protocol move on to a rate control. What do you use? First line, second line, and anybody less than 110 is safe to go home. And then the rhythm control, obviously, the rhythm control, you can see it's the biggest one, although this should be the small proportion. I personally wouldn't. I try my best not to cardiovert anybody. I always say let's put it this way, 75-year-old patient coming with AF, not known AF, and then to your mind, oh, she's within 24 hours. Okay, so how do you know that she's not paroxysmal AF? How do you know that not every week she gets that and you don't know about? How do you know that there's a thrombus sitting there waiting for you to throw it to the brain? So, all these questions. So if the patient is oldish, they got hypertension, they got other vascular risk factor. If they come with AF, even though it's within 2 hours, it's most likely not just this event. If they are 40, they binge drinking and coming on Monday, then yes. Does that make sense? So those patients who meet the criteria, they don't have signs of heart failure, no ischemic heart disease, ECG doesn't show any other abnormality other than AF, essentially, we agreed to consider flecainide on them. Okay, and there is protocol for flecainide for you in that pathway as well. But most patient is a wait and watch approach is appropriate as well, unless they are compromised. Then you shock them, obviously. And I just brought this shock pathway from ALS guidance because there's nothing different to what you would do anyway. In addition, I've added the SHAD-VASC kind of criteria, who to consider for SHAD-VASC, sorry, who to consider for anticoagulation, who is not, that just to help you going forward. This is when the patient comes to ambulatory care unit. This is for ambulatory care unit ACPs and team to do a few more things for the patient. Essentially, it's all about making the flow in ED much smoother. Essentially, it's more about identifying those patients, where they should go, and move from there to different areas, particularly ambulatory care units. And we've approved those drugs for you as well from our pharmacy department and cardiology as well. So these are the current medication that should be used. And the flecainide as per the cardiology, that's how the flecainide should be used. So you need to make sure there's no ischemic heart disease, no LV dysfunction, no major ECG changes before you proceed for flecainide if you decide to rhythm control somebody within less than 24 hours. And that's it. So that should be available. It's really straightforward one. It's 4 pages, but for you, your patient will move to one category or the other. You don't need to follow every page for that. So most of them are rate controlled essentially. So I hope you find that useful as well. What I'm finding though now is patient bypassing all this and jumping to this box 110 to 130. Oh, patient meets criteria for ACU. Let's send them up. That wasn't the idea. The idea was to do something and then send them to ACU. But anyway, it doesn't matter. It seems they are all right with it. So let's just keep going. But yeah, the idea is if you can give some rate control, we know that sometimes takes about 2 hours, 3 hours to rate control somebody. And that's why I allowed that box where you could actually get them up to ambulatory care unit.
But now we have got acute medical decision unit.
I know. Yeah, it's coming on December as well. Big
it's
change.
Easy for us. We will push these people to there.
Yeah. Look, again, back to the idea. This pathway is good if you reuse it right. If people just follow it as it says. If people ignore it, we're just gonna go back to what we've been before, especially for ICH. As you said off top, if people don't know it, they just sit down and refer every single ICH patient to, it's like what, an hour wait to get results from them even? I think at least an hour between you referring. Sorry, Rachel, you were saying.
It's often more, you're ringing them and chasing them.
Well, but it's waste of time. And then what is it, 95%? 95%, sorry, thank you. You know, like that was, yeah.
I think from ED point of view, for instance, we neurosurgical referral. So we've got a traumatic brain injury, yes, which of course is a surgical situation.
So just to be careful after, we're talking about spontaneous intracranial bleed.
Absolutely, and we got a spontaneous intracranial bleed now.
Yes.
Now, I think spontaneous intracranial bleed, we do the scan. If it's not a subarachnoid bleed, I think, during the night or something. So I think, ask help. Subarachnoid bleed is a bit different because their bleed can be from aneurysm, whatever. So they have to do CT, angio, or they want to do something about that. But the parenchymal bleed, so we're talking that situation.
Yes.
I think there we need to look at these guidelines. So in case that, the time is saved.
And you literally, honestly, as you said, 95%, you would not need the neurosurgeons. 95%. And
I think it's easy for us, is it? Because here the help is available. And the first principle working in ED is, seek help. So because our main aim is to dispose patient to safe sort of situation.
Yes. Where's the safest place for patient, isn't it? Where is this patient?
Yeah, you're right. Yeah. So, make patient safe and then send patient to a safe place because we don't have our own accommodation where we keep the patient.
Yes.
So it's easy for us if we have a, acute stroke consultant and team available. I think if we won't use it, then I don't know, then we are a bit sadistic, is it? Because we like to be troubled. I think,
I don't know about that.
No. I mean, ED doctors are like a little bit eccentric. So the other thing is like, the bisopolar, we could still, I can still see sometime that the clinician have prescribed 1.25 milligram bisopolar, 2.5 milligram bisopolar. Yeah, I think we have to up that game because that will do nothing in new sort of onset atrial fibrillation. Yeah. The other thing is a heart failure and the bisopolar. I think could you please enlighten us on that aspect as well?
Yeah, as I said, from the one that you should avoid for sure is calcium channel after heart beta blockers in the heart failure is recommended, but not in the acute phase. Sometimes they advise not. But if the heart failure is because of the AF, then all you need to do is the rate control. So beta blocker remains first line. Having said that, we all know that digoxin have some inotrope effect, isn't it? And digoxin is good in heart failure. So if the patient is a bit more older, is a heart failure as well as the AF, then digoxin might be better. Even amiodarone as well helps, but digoxin is better. What you need to avoid 100% is calcium channel. Definitely not.
Fair enough. Okay.
So if you had to choose between beta blocker and digoxin because of asthma, for example, then digoxin. If you got heart failure, if you had to choose because the patient is young, is oldish, and a bit of like, you know, not very active, then digoxin, because then you can start IV digoxin loading and then move on to digoxin long term. And again, you know, the 1 to 3, back again, same idea. This is not 1 to 3. This is just 3 drugs. Pick and choose, whatever suits the situation, isn't it? But calcium channel blockers are no in heart failure. Digoxin is perfect. Bisoprolol, if the heart failure is because of the AF, then it's still the same. You will rate control. You will slow down the heart. The heart failure will improve.
Excellent. And the cardioversion, we stick to our ALS protocol.
Well, for the compromise one. And I personally would say, honestly, from stroke point of view, try to avoid cardioversion. Try not to be brave and say, oh, he's within 24 hours. Only if you really, really feel it is within 24 hours and you're really, really sure he doesn't meet any other criteria. You know, he's a 30, 40-year-old who had a bit of drinking last night and he's coming with AF. I'll give him flecainide, because flecainide is a chemical cardioversion as well. So flecainide, amiodarone are chemical, and obviously you have the electrical choice as well. So if you can avoid cardioversion for those stable one as much as you can, that's best. That's the wait and watch approach is better, but by any means do it for the younger, but not for the older.
Fair enough. I mean, during the night, you know, giving flecainide probably is better to seek bit of help, bit of advice. But otherwise, remember them 3 drugs: beta blockers, digoxin, and what the calcium for the verapamil. So just remember these 3 drugs.
Yep.
And the verapamil don't give to people who got a heart failure.
Calcium channel, yeah.
It's simple, is it? Simple and easy. Excellent.
That's what it should be. And don't refer straight away to ACU. Try to give them something on the way up.
Probably.
Because by the time they get there and get seen, you know, you would have given, let's say, if you say, okay, he's 110 to 130, I'm going to give him 5 milligram bisoprolol oral, do it. And then by the time they come up to ACU and seen by somebody, then the heart is rate controlled, then bang, out. So
no, the ACP, they are very clever. They will always say to you, oh, can you please give some something?
Yeah, okay. Well, good that they're doing that, because I saw some patients being bypassing the pathway straight into the rate. But it is what it is. So I know how busy you are, guys. And honestly, I always say in my, you know, kind of way of talking to people, I'm pro ED. I want to help. And that's why, I mean, so far 2 pathways. 7
well, no, I must say, you know, the younger consultant in specialties, they I don't know whether they have worked in ED or not. They're very sympathetic, but the older one, they still think that we are a bit of triage service, honestly. So, you know, so I think my challenge to them is, can they come and work with us? You know, so
I think because acute medics worked in ED.
Yeah, you're right. No, Anu Agrawal, he is planning to work in ED. So he was telling me that he will come and do a few sessions in ED. So
he's our divisional director.
Absolutely. Yeah, so he would like to have the first-hand experience. I say you're most welcome. But come in the evening.
I love Anu. I love Dr. Agrawal. He's great. I think it would be good. We've got good medical structure now. I think we'll be fine.
No, we are looking.
Just need to work together. That's all.
We are looking a lot of improvement in ED, quite frankly. You know, I mean, our research is absolutely, scandalous. It's absolutely, I don't know. It's really an insult, quite frankly, you know, to the patients and the people working in our research. I keep on telling that, you know. So I told them that sometime I'll bring the public health service. Believe me. So I will get the environmental public health service here. It's the insult. They're not, I think now Marie Hardacre, so she is saying that she is working on it. I think it's some sort of big manager now. So she is saying that she's working on it, and she promised me that the work will start soon on research.
Yeah. Well, you know, I haven't said that after I worked with you guys as a Q Medicine ST3 2014, and for those, I mean, the guys on this session today, they may not know the AD has improved dramatically over the last 5 years. Absolutely. It just needs a bit more time, and we, as I said, a few little things here and there, we can work together. I'm doing my part from acute medicine and stroke medicine. There must be other people can do their parts as well. We'll just keep doing it, and hopefully we'll get better and better.
No, there are a lot of help. Is orthopedists are helping us quite a bit. Surgeons are still a bit lacking. They're wanting.
I was waiting to hear their opinion on the new standards, though. Anyway,
medicine really has helped since I think the help start happening when Tim joined, and then Nick came along. So these two guys have really helped us a lot in medicine. Initially, if we used to refer STEMI, you know what the answer used to come? Can you